Recording. Okay. First things first. So what I did was this. This is just a doc that I put together with. Yeah, I don't even know how much you'll be able to see of it per se. Let me do it this way. I'll download. The other's a screenshot. So I'll download that and we'll take a look at it. So that's my most same thing. My most recent set of lab tests. So you can see the normals that are there, and these surprising enough they were all good.
Is this oh? What are you talking? You're the bill of health doctor.
No, really not. You'll see. I say 100. I mean, so this is. I have to do these every 3 months for whatever, for a medicine I take. And the reason I was not up to speed on Monday is I take an injection called Humira, which you see on TV, which we're going to touch on in the immune system. Is a form of anti-tumor necrosis factor. So tumor necrosis factor is an agent that basically is part of your immune system. It's an immune stimulant, if you want to think of it. This blocks its activity. It's particularly useful in people who have psoriatic arthritis or variants. I take a shot every 2 weeks. I get a resounding headache. And, I had a resounding headache the other day on Monday. And still, I mean, there's still a certain residual, but just take a look at the numbers that are there. So when you sodium, potassium, chloride, now it's carbon dioxide. We used to call it bicarb, and so these, you basically looked at these different things, and you came up with something called the anion gap. It's the distinction between positive and negatives. That were there. These are all, as you can see, within. There's no flags. BUN. We talked about. And we will certainly touch on it again. Kidney function is based on excreting nitrogenous waste products, and the principal one is called urea nitrogen. So it's basically from amino acids. It's the deamination of them, and so 9 to 23 glucose. And every lab is different. This is roughly 70 to 100. This is not a fasting, but a random glucose. I didn't have to do a fasting glucose for this test. 88 is fine. Creatinine, you can see right in the middle of the range. That's another very, very good. The creatinine and the BUN are really your best measures for a snapshot of kidney function, the importance of calcium, and then some enzymes, alk-Phos with overly active arthritic changes. Sometimes you'll see that. Bilirubin, again, if you have, like we've been talking about now with hemolytic aspects, protein levels, you don't want to be too low because of colloid osmotic pressure. Too high, that overactivity can really produce a significant degree of problems vis-a-vis the blood. Albumin, the most abundant. These are, again, enzymes which are sort of, call them for the time being, looks at liver frequency. Here's that anion gap I was telling you about. Again, a general measure of kidney function, and they look at the ratios that are there with these as well. And what they're able to do is estimate the glomerular filtration rate. Here's the osmolarity, which we have talked about and we'll certainly go over. In kidney, it's supposed to be around 300. So plus or minus is a good range. And this is a way, without having to do a comprehensive test involving collecting urine for 24 hours, of being able to estimate your glomerular filtration rate. And certainly as we get older, that begins to fall down a bit. And you begin to be at an increasing degree of risk. And there's other things. In men, you have prostate problems that can add to it. And I've had prostate surgery and other things that add to it. So that's it. So you can see where, there's some little differences there. And that my rheumatologist, that's Dr. Devich, is the one who orders it. Not done yet. I got a couple of screenshots to do the blood, since it sort of amplifies the unit. You should feel privileged. You're the first class I have revealed.
Yeah. Nice. You like this that much?
So I know I'm revealing myself.
He loves us.
No. Tolerate. So here we are. And maybe I can I blow this up a little bit? I suppose I can. Here we are. So these are, when you look at, remember we were talking about eosinophils, lymphocytes, monocytes, neutrophils. These are the ones like the immature type forms. Why this is a skosh high, I don't know. Who knows? And again, this is the same set of bloods that I had during that time. So if everything else is normal, typically what a physician's office will do, they'll look at these, do a quick review, and if something stands out, they'll get back to you, or and if they say, hey, look, basically these are fine, nothing. And for all I know, this could be a side effect of something that I'm taking. Remember we talked about basophils, 1, normal, EOs, 5, based on a percentage. Here, you can see this is my problem area, my H&H. Okay, hemoglobin and hematocrit. And roughly, as you can see, if you take the hematocrit, this which we should be able to at least simulate in the lab if we choose to. No one has to do any of this stuff. That's low. I mean, it's under 37, even for this is for men and women, both, but still that's relatively low. And this was a couple of units, like think of this as roughly 3-month intervals that are there. Now I'm up to 39, which is good. So I've been doing vitamin supplements. My lymph's 35. These are the indices, and we'll show you those in the next one. Famously, they're referred to as the Wintrobe indices. I will blow it up a little bit. MCH, MCHC, and MCV. Mean corpuscular hemoglobin. So a corpuscle is a red blood cell. So the average hemoglobin, the average concentration of hemoglobin, and the volume. And this is the big player. So those cells are big. Okay, the normal cell should have a volume, whatever that is, 94, whatever that means. And notice almost consistently across these, mine are high, high, high. That's enlarged. So when you have a macrocytic anemia, so the anemia was from the hemoglobin and hematocrit, even though now they're in a good range, the big H there indicates that my volume is high. So that's called a macrocytic, and at the time, a macrocytic anemia. That's why it was either going to be B12, and when they assessed B12 levels, they felt that they were a little low. And so I started on, and they're not expensive at all. There's not a big problem taking them. The good thing about most B vitamins is that whatever you take, your body uses, and you excrete the rest. So as long as your kidneys work, you can't, it's not 100% true. There are some you do have to be careful with regard to that. And then we can see the other thing. Neutrophils, okay, 46%. Yeah, is a skosh on the low side, a little bit. Who knows? Platelets, right where they're supposed to be. My red count, argues more to the anemia, still a little low. Okay, so you can see that's there. So I did want to share that with you, and you can see how low it was. I mean, that's fairly low. That 366, that ain't great. So, I mean, to give you an idea, and now you can see where the numbers were, understand, just to give you an idea, and it's more about what happened to me than anything else. But way back when, my hemoglobin, when I had my second major abdominal surgery, was under 6, was about 5.2. And that was after I had gotten a 3-unit transfusion. I could have been done anytime. So that's that. But now, no. Thank goodness for that. Moving on. Let us finish up on the blood unit now. So a little note about these thromboembolic disorders. What's interesting about thromboembolic disorders is undesirable clot formation, and then bleeding disorders as well are in a different category. So either they're going to be more likely to clot or more likely to not clot. And they both present significant problems. I would think, to be fair, most of the problems are in the thromboembolic disease aspect of things. They are a big problem associated with, over time, with damage to blood vessels. What effectively happens, and you saw a little bit of it when we talked about clotting, the exposure of collagen. So if you go back anatomically and look, the area underneath the lining, the endothelial lining, the simple squamous, is where you have that loose areolar connective tissue. There's exposure of collagen. Where we see damage is there. What happens is that seems to be the area where we see a combination of depositions of fatty materials. We see inflammatory changes. That's why anti-inflammatories are a useful additive or a useful adjunct therapy for a lot of people. Why sometimes it's as simple as taking a baby aspirin a day, which inhibits platelet aggregation. So these are all useful therapies that, and what happens is that sort of mound of material begins to push out what normally should be a smooth lining with a bump in it. And anytime you have a bump, turbulence. And then whether it's excessively, no, and the more bumps, the more turbulent, the more narrow the lumen is, the more likely you're going to see either platelets slamming into each other or red cells slamming into each other and starting this thromboembolic process. A thrombus is a clot that forms. An embolus is either a clot that breaks up in its entirety or partially. The best known of all of these clots are ones that generally come from being very sedentary or in a hospital for a long period of time that form in the blood vessels deep in your calf called the soleal sinusoids. You might remember from anatomy, a wide flat vein is called a sinus, like the coronary sinus on the heart. And this is the area where most of these really significant clots form. And when they embolize, they make their way through your venous system. So effectively, eventually they get into the very wide, they're going progressively wider. From where they are, they're going into the femoral vein, they're going into the common iliac vein, they're going into the inferior vena cava. And then when they get to the heart, they're still in a fairly wide area. When does it start to narrow? In the pulmonary artery as they get smaller and smaller. And so that's where they form pulmonary emboli. And those emboli can basically think of a block as your heart's trying to pump blood into the lung. And that is a major cause of heart attacks, heart arrhythmias, decompensation is the term that frequently is used. So that's what you're going to see. So undesirable blood clot formation. The opposite side are bleeding disorders. And a lot of times, sometimes they're medication related, sometimes they're hereditarily related, which I'm sure they'll comment on some of these, whether we're talking about absence of certain clotting factors and genetics. You surely did hemophilia A and hemophilia B, right? You had to. Okay. All that. Where'd it come from? Why was hemophilia A so well known in Europe? God, you guys. History. I know you're science majors.
So, what, famous hemophilia?
Yeah. So who most famous?
The French czars. The French czars are right.
The
Russian czars.
Russian czars.
Russian, not French. Russian czars.
But they were all, because all the crown heads of Europe intermarried. It was a way to achieve political stability. Royalty married royalty. So it was like, and most of it came from the Queen Victoria's bloodline, and she married effectively a German Belgian prince, Prince Albert, and they had 7 kids, and that was really where the lineage came. So a relative of theirs was eventually the Tsar, and very famously, that was the last Tsar, the one who was murdered in what effectively became Stalingrad in 1917, and it was called that. It's very famously referred to as the House of Special Purpose, and the reason, and that was during that crazy monk Rasputin. Okay, and so he was sort of a mystical character, and the child, the prince, who's the future czar, had such bad hemophilia, and hemophilia would bleed spontaneously into joints, extraordinary pain, and Rasputin seemed to have a magic way of calming him. That's why he was part of that family. Very, very interesting thing associated with it. So very much hereditarily oriented disorders. There was no treatment. Now we're able to supplement the clotting factors. There's transfusions. There's genetically made clotting factors. So we can deal with that. That was hemophilia A. A little less common was hemophilia B. Hemophilia A was factor 8. Hemophilia B was factor 9, a little less common. That's all. So all of that. Now, DIC is a little bit of, it's fascinating. We had a dog that died, but it was indirect. Where we see that is in, I don't know if you covered it in micro or not, it's called gram-negative sepsis. So what happens, think of a ruptured bowel, a tumor, which is where the dog had the problem, in the bowel, and that opens up, and the bowel contents, which are rich with gram-negatives, lots of E. coli and its cousins, coliform bacteria, pour into the abdominal pelvic cavity, and it sets up a massive reaction because gram negatives, the lipid A portion, is an endotoxin, so it's endotoxic shock. Sometimes we'll see this. It will gobble up the clotting factors. So when it gobbles up the clotting factors, interestingly enough, we get a combination of dramatic bleeding, and we also get a dramatic factor of clotting that occurs simultaneously. And interestingly, historically, the treatment was to use heparin because you were worried more about the clotting than the bleeding, which eventually you had some ways to treat. So typically, it had a bad reaction. I remember the dog, its limbs became very, very swollen, edematous. It was wonderful. It was 150-pound, not Great Dane, 150-pound golden, enormous golden Murphy. My kids, all the kids in the neighborhood, he'd sit outside and in front of our house, and the kids would all come up and pet him. He had that fabulous demeanor, but he only lived to be about 7 years old. And the difficulty a lot of times with purebred animals, which he was, when they're trying to get the size or the coat, is you inbreed and this is part of what happened with the crowned heads of Europe. You inbred genetic recessive traits that were periodically problematic because a lot of them had heart problems. They had notoriously large dogs like that have hip problems. They don't live very long, compared to your basic mutt. The Pittsburgh variety, Heinz 57 variety, or a doodle. We know something about doodles. Where it must be indigenous to North Allegheny, because my wife's mom and my wife, most of her teenage years and later years were in McCandless Township. Every time we bring our dog over, he gets loose and runs around that neighborhood. There was another doodle yesterday loose in the neighborhood. My wife was helping to chase down. It obviously affects doodles that way. Just saying. Moving on. Thrombus, clot that develops and persists in an unbroken blood vessel, circulation, death, you can imagine, heart attack, stroke, etc. Embolus, portion or all of it breaks off. So embolic disease, pulmonary or cerebral emboli, which causes stroke. Atherosclerosis, inflammation, stasis, immobility. So what we do, for those of you in a medical sense, what we try to do is get people up right away. We would do hip surgery, this is 50 years ago, on 90-year-old people who break their hips. We'd have them up in a chair that day. They'd be down in physical therapy, learning how to walk with a walker the next day, because you wanted them out of bed. And that's why, and I'm sure I've commented on it before, why when you're in bed and you can't get up, they use those intermittent compression devices, which I like to call squeezers. They put on thromboembolic hose, which are called TED hose, which I don't know that they have to be put on properly. That's another lecture in its entirety. And then alternate compression, 20 seconds on to compress, basically circulating your blood for you when you are unable to do so. And I had those on when I had that second surgery, and I was very, very ill, to say the least. I had to spend 9 days in the hospital to get healthy enough for them to discharge me and bring me in 3 days later to do an operation where I was in the hospital for another 10 days. All of that in June of 2000. Just saying. My 14-year-old daughter is throwing herself on me and go, "You're not going to be around for my wedding." She's still not married. I keep reminding her of that. Moving on. Anticoagulants used to prevent aspirin. It's a prostaglandin and inhibits thromboxane A2, lowers heart attack incidence by that's for a lot of time. And it's a small dose, like a baby aspirin is a quarter of a regular aspirin tablet that you would buy. Okay. In the old days, we used to measure things. They were called grains. They were called apothecary measures. Now it's grams and milligrams, but grains were about 60 or 65 milligrams, as I recall. So baby aspirin is about that size. Heparin, okay, this is by injection. So a lot of times we'll have people on this. They use heparin locks. So if you have an indwelling catheter, you want to be able to pull blood out of somebody or give fluids to somebody, but not constantly. We would have that in there. It would periodically clot up. You'd inject it with a small amount of heparin. It would clear right away, and then you could start your IV. Or you can, because the line was already there. Now, most commonly for years, warfarin compounds, which were oral. A lot of different things. They interfere with vitamin K, which produces a variety of clotting factors. The difficulty with warfarin or Coumadin compounds is you have to monitor all the time, okay? And you need to keep it at a level. You have what's the active level, the patient level, and a control level, and you want it about 1.5 times, as I recall. So, I mean, and my wife they used to run these all the time in the nursing homes, and they have to call the physicians with the results because you're constantly altering the dosage. And so every other day they were doing, it's called PT or prothrombin time. Just saying, not enough platelets. This is more common than you think. It produces we classify when you get bleeds under the skin by what they look like. Tiny little dots are called petechiae. Okay. And when they're very large, like blotches, they're called purpura. And so sometimes when you have an absence of platelets, there's a famous disease called thrombocytopenic, which means you don't have enough platelets, purpura. And I have seen that happen with patients because very often, not as it's these spontaneous hemorrhages typically have to do with medications. It's not that unusual if you see them associated with cancers or cancer treatments, but the platelet counts get low, and that's when you end up with platelet transfusions. And that's why I was saying that a lot of times when you have to replenish clotting factors, and that was typically done, I do not know if it still is, with, as I said, for and unfortunately, when I talk about open heart surgery, it's very sad because my dad didn't survive. And my dad was extraordinarily physically fit man, 6 feet, he's 74 years old. I will be 72 in May. 6 feet tall, 182 pounds, 32-inch waist. It's like, you didn't mess with my dad. Some wonderful stories. Those are what petechiae look like. And so if they turn into blotches, it's kind of like we do that thing for we have different categories based on size. Like if you get a tiny blister, it's called a vesicle. If it's big enough, it's a blister. If they're large, they're bulla. And then if they're even larger still, they call them blebs. So there's a whole nomenclature thing that goes on with it. So liver function. You can't make the clotting factors. Classically, vitamin K deficiency. We see it in hepatitis. There's a lot of causes. Surely the most common cause of hepatitis, alcohol. And I'm saying that to all of you now. Because what happens, at least, if you did not know, you have to be to become cirrhotic, to get alcohol, hepatitis, or cirrhotic, you have to do some very serious drinking. We're talking about, 6-pack a night, bottle of wine a night, every night, for like 10 years.
It's crazy.
Yeah. There's a difference between liking your beer and that. Yeah. And I always felt that the distinction, if you have somebody comes home, and my kid does that in the Navy, and obviously not when he's on a ship, but typically he'll come home and he goes, Dad, I have a couple of beers when I get home. I'll see when he gets back from work, and we're visiting. And the difference is, well, what happens if you're out of beer? I mean, are you running out to the store in the middle of the night to get it? And if the answer is no, then that's not alcohol. Take it from somebody who's an expert on addictive diseases, having had them. I mean, I would be feeling the cigarette pack here. And when it got a little low, I'd be making sure I'd get to the store before it closes in the pre-Sheets days. Yeah. And if it was the middle of the night, there'd be a Sheets run. That's an addiction, full blood. So all of those things are part of it. Liver disease, prevent the liver from producing bile, which is needed to absorb fat, and vitamin K because it's fat-soluble vitamin. So there's a lot of nuances to that. Hemophilias that I just mentioned, the hemophilia A, factor 8, hemophilia B, 9, hemophilia C, factor 11. These are a little bit milder, certainly not, but you should know that A and B and what factors are involved. Bleeding, particularly into joints, a lot of genetically engineered factors. There was a big problem, I'm going to get to it shortly in this chapter, is we now screen the blood much more closely. So you may have heard me mention it to you about my first wife back in 1981 when she was having ovarian surgery, probably was exposed to hepatitis C. The blood banks did not screen blood efficiently for either hepatitis C or HIV until 1987. The very famous tennis player, Arthur Ashe, who succumbed to basically their feeling was that he contracted HIV/AIDS from a transfusion for open heart surgery, I think right around that same time, 81, 82, 83. I mean, so, and, you know, he had won both the U.S. Open and had beaten Jimmy Connors in Wimbledon one year. So he's very, very, very well known. Originally from Richmond, Virginia, by the way. Because when I trained there, everybody knew about Arthur Ashe. So a lot of what I'm telling you today is because the screening is so much more different. All of my transfusions came between 1998 and 2000. And so, and even though she and I, my first wife and I think we both had A positive blood. I'm pretty sure. This is a very, very common blood type. So it's not a difficult cross match, but every time you get a transfusion, it's not your blood. You know, assuming it isn't an auto transfusion, okay, it's not your blood. The safest blood you can have is your own blood. So a lot of times someone, let's say they're having a hip surgery or they're having the aforementioned open heart surgery. If they can, they might donate their own blood, large plastic surgery procedures. They'll donate their own blood X amount of time before, let's say within a 2-month window. So it'll be on board for the surgery. Then the next safest blood, some people think it's what's called directed donation. Oh, my Uncle George has the same blood type. Statistically, blood bank blood is safer than directed donations. If you have a relative who wants to put blood in to make up for the blood that you had to use from the blood bank, that's great. That's wonderful. That's commendable. It's not, you know, you don't know who Uncle George's been hanging out with, if you know what I mean. He could be getting frisky with somebody we don't know. Just don't look at me like that.
You don't want Uncle George blood, that's what you're saying.
Right. Let the blood bank deal with it. Okay. DIC, clotting and bleeding, intact blood vessels, blocking blood flow, severe bleeding because residual blood is unable to clot because clotting factors are being depleted. Typically septicemia, incompatible blood transfusions we're going to get to, pregnancy, amniotic fluid that gets into circulation can lead to that. So traumatic deliveries potentially could create that kind of a problem. I do not know how commonly that happens. So what happens? Minimizing the effects of blood loss by reducing volume of affected blood vessels, stepping up productions of RBCs. So when there's injuries, blood vessels go into spasm, there's increases. We can only compensate for so much. Okay. Understand this is on an acute basis. So a sudden blood loss, terrible accident, gunshot wound, stab wound, okay, 15 to 30%. So you're talking about a third. That would take, if your normal was 15 down to 10. Hemoglobin. pallor, looking very pale, weak. 30% or more than that, severe shock. Understand, my blood loss, where it was 2/3 of normal, was over probably a 2-year span. So chronic blood loss, your body develops a certain degree of compensatory mechanisms that were there. That was 2000. My uncle had died roughly at age 80, my mom's brother. And at the funeral, we went both to the funeral and to where everybody got together at one of his son's homes. I looked worse than anybody else did, and I was not even 50 years old. People were shocked when I walked in with difficulty. That's how bad I looked, and that was right before I went in the hospital to have more transfusions and surgery. Okay, so what happens is when you lose that much blood so rapidly, shock ensues. Shock means that there's insufficient volume of blood to maintain blood pressure. Without blood pressure, things start to happen. Your body is trying to compensate by opening up blood vessels. Eventually, the blood pressure just keeps lowering and lowering. Your heart's working harder. So we see pulse rate goes up, blood pressure goes down, insufficient circulation. People are very cold and clammy, perspire a lot, and at that point, their pulse is very, very faint, and eventually the kidneys lock down, and then big trouble. So, even in an acute phase, if somebody's like that and you see those kinds of things, and you just have to touch them, they feel cold and clammy, and their pulse is very rapid, at the very least, try to make them warm and try to prop their legs up. Okay, you want them in a position where whatever circulation is called Trendelenburg. We use it in surgery. Okay? So you want to put your level of your ankles higher than the level of your heart to allow for gravity to assist you. It's just basic first aid, but maybe one day it'll be something. You have to replace volume immediately. That's why a lot of people use ringers, or what's called lactated ringers, because it's kind of like it's very close to the electrolytic balance that's there. And then obviously you have to be able to replace the red blood cells. So there's a lot that's involved with it. So typically you don't use, I mentioned this before, whole blood transfusions right away. Whole blood transfusions are secondary, and typically only for that immediate blood loss. When someone's in that accident, the gunshot wound, the stab wound. And it was a privilege, but it was scary because I was a resident for 2 years in a very rough inner city neighborhood in Philadelphia, in North Philly. And we had them in the emergency room every day, gunshot wounds, stab wounds, all the time. I wasn't anything, it didn't shock you. Okay? It was like in the movies. All of a sudden the door would open, a car would come by, they'd open the door, they'd throw in the person who was bleeding, and the car would race off. Can't even tell you how much. Scary. The guy was stabbed 16 times because in those days, check day was the first of the month. They got your welfare check, and some guy was stabbed 16 times for an old man, probably my age now. The only reason it saved his life is wearing a heavy coat. It was winter. I remember we operated on it. So what do we do most of the time when once you've stopped the initial bleeding, then you supplement with fluids and, as I said before, pack cells or pack red blood cells with the plasma. And the reason why is not just because it's all about oxygen carrying. Where we see a lot of problems, where typically in the plasma and in the protein, in the fibrinogen, historically was where hepatitis B was typically found. Okay. And in the white blood cell fraction, okay, in that buffy coat I talked to you before, that's where white blood cells are. That's where HIV is found. So it was even before we knew about those diseases, it was statistically safer to use packed cells. And so all of the blood that's donated, and as you can see, the shelf life is barely more than a month. Because again, with those red blood cells, I guess the formula is such that if you wait till 2 months, that the half-life of too many of those cells has started to go away. And you're effectively having a not beneficial transfusions. And so everything else here is based on something that we're going to go over, the whole idea of blood groups, transfusion reactions, and the distinction, even though I'm sure you've had it a zillion times, but it doesn't hurt to do it again. It's a fascinating area because what we have is something that is as easily overlooked as any. And I will tell you the same anecdote I have been telling for forever because it's true. It can happen to any. Sometimes the simplest thing is what people forget to do in a critical situation. Now we do a lot of liver transplants with live livers, but when liver transplants started circa 1980, so around that area here in Pittsburgh, which is really where they go in the Starzl Institute, because Dr. Starzl came from the University of Denver and was recruited here in Pittsburgh and became one of the leading transplant centers. And my cousin's first husband died on the waiting list, and she had called me about going to Pittsburgh and all those things. And he got a 28-year-old man, very sick, from some type of, not from something, some defect in his liver that he was born with, as opposed to with drugs or hepatitis, because it wasn't like that for the future, or unfortunately for her. Nevertheless, at that time, there was a very famous case, and it didn't happen at some small town hospital. It was at Duke University Medical Center. So on the top list of top 10 hospitals in the country, it's there. And they had, at that time, they would flow in, you had a 24-hour window to implant a liver. Well, they had flown a liver in that was on their donor list, called the core list. Okay. And it was there. The patient died just as the liver was arriving. But fortunately, within a half an hour away, they had a young woman who was in need of a liver who matched the profile. So they immediately transplanted her. Very successful, the surgery initially. 3 days later, she died. They had done everything right with the surgery, except they forgot the one thing that a first-year medical student would have been, they didn't check the blood type. It was like she was B and it was A, or she was A and it was B. A major incompatibility, boom, giant transfusion reaction, she died. Duke! Okay. I mean, you figure it out. Cedars Sinai, UPMC, Presby, Duke, Cornell Medical Center in New York. Figure it out. So that's the idea. If for those of you who go on and work in hospitals, weird stuff. That's why, and I say it time and time again, doing a transfusion is easy. You're hanging blood. Big thing of blood looks like an IV bag. So it's got blood in it, put in an IV, happy dance. Okay? One person can't do it because you have to have two people sign off on it. They're going to check the patient. They're going to check the patient's number. They're going to check it against the blood banks. They're going to check the blood type. They're going to check, and they both have to sign off on it because that can happen. So it's like, how many people does it take to hang blood? Minimum of 2. So all of that stuff. And so this is when we get into it, and we'll do it right before. We'll probably do it as we prep for the lab on Monday and basically do the whole thing. But the interesting thing to me about it is you have 2 different genetic things. You have multiple alleles, okay, and the idea of codominance integrated with traditional Mendelian genetics. So the positive and negatives are traditional Mendelian genetics. And the ABO system is multiple alleles, meaning rather than having just 2, either dominant or recessive, we have a second dominant. And the most unique thing about the whole system is normally, what's the least one we see the least? 2 recessives, right? What's O blood? 2 recessives. What are 2 dominants? AB, the least frequent. Go figure. And I've never really been able to find a reasonable explanation about that. All I can tell you in closing is that if you're going to have blood, have either O positive or A positive. That's the easiest to find. I'm fortunate mine was A positive, so they never had trouble matching me up. And that's why I was here to give you this talk today. Have fun storming the castle. I am working on your, I finished the exam. I will try to get out maybe as early as this afternoon, tell you what's on it to study. And for you guys, I have to go over it in class. I unfortunately posted, and you'll never get a break like that again. Your grades. Never. Never will people who got less than 50% pass.
You said the house is 72, right?
What?
The
Yes.
house is 72. So it's the majority below 50?
Right around that. I think the median was right around. How? Don't ever do that again.
Let me tell you, it was the first question, the first 5 questions, last 5 questions. 10 points right there.